Good afternoon, everyone. I welcome you all to this session called Exchanges in Primary Care. It is a fortnightly session which we have on first and third Saturday of every month in the afternoon at 4 p.m. It is a very informal platform where we have people working in primary care at the grassroots, in the academia, in the health system, or in the research segment, who come and share their work, share their learnings, or share the dilemmas or challenges which they are facing. So it is done in a very informal manner, and we generally have a small group, but the group is of consists of people who are actually involved in primary healthcare at a very deep level, and who want to want to learn from this and try to implement, or maybe take it ahead. So the discussions which follow after this session will become very engaging, and they become very useful to people who are actually working on the field. So that is a brief background about this session, which we call it as EPC, Exchanges in Primary Care. Today we have Dr. Hemant Shevade with us. He's a scientist with ICMR. It's an institute called National Institute of Epidemiology in Chennai. He is going to share with us an interesting and a very simple tool, a TB risk predictor tool, which has been used in Tamil Nadu, which has been tested and proven to be very useful in reducing mortality due to TB. I think it becomes quite relevant because, as we know, our government had set up a very ambitious goal of eliminating TB by 2025, but we know it has not worked out. And now everyone is looking for answers or looking for approaches which can be useful to reducing the burden. So I think this becomes very useful from a primary care perspective, where we have our field teams and systems in place to identify patients and to deliver interventions which help in actually reducing TB mortality. So without saying much, I would like to invite Dr. Hemant and share his presentation, and all of us can learn a lot from this. Thank you, Dr. Hemant, for agreeing to share on this platform. Over to you. Please take it up. Yeah.
Thank you, Sham. Thank you, colleagues from BHS. So what I'll do is the presentation is for 40 minutes, but I'll try my best to complete it in 30 minutes so that we have more time for discussion. And my humble request to those who have joined to please note down the slide number and your comments so that we can take it at the end. I'm starting my screen share. Okay, Sham, if you may confirm, you can see my slide.
Yes, it is very clear. Yes, we can see the
And
slide.
I'm now moving this to the second slide. You can see that, right?
Yeah, we can see the change. Yes.
Perfect. Thank you. So let me begin.
Yeah.
So hi all, welcome. So I'll be taking over the next 30 to 40 minutes, taking you through our experience of implementing the first statewide differentiated TB care initiative to reduce TB deaths that was implemented in Tamil Nadu between 2022 and 2025 for a period of 4 years. The initiative is called as Tamil Nadu Kasanoi Erappila Thittam. So our colleagues who do not understand Tamil or are not experts in Tamil, nor am I, but Kasanoi means TB, Irappu means death, Erappila means death-free, and Thittam means a skiing project or an initiative. So I'll be using the abbreviation TN-KET throughout this presentation, and those who are on social media, LinkedIn, Twitter, Facebook, YouTube, you may use this hashtag TN-KET to search for more content related to TN-KET. And the 4 QR codes mentioned below, provided below, have everything that I'm going to present, not just what I'm going to present, even more details if you want to know. You can access these 4 QR codes that are at the bottom of the slide. I'll repeat these 4 QR codes again along with the thank you slide. Before I begin, permit me to acknowledge this is not being implemented by me. This was jointly implemented by State TV Cell and ICMR NIE. In fact, if you ask me, this was implemented by Tamil Nadu, led by the State TB Cell. It was implemented by all the 3 key directorates of Tamil Nadu. It was implemented in routine health system settings using available resources. ICMR NIE just provided lead technical support in planning, implementation, monitoring, supportive supervision, and operational research. Let me just remind that this was not a funded project. This was a non-funded project. So this is a very good example as to how academic and research institutes can actually work with health systems. Health systems have their strengths, academic research organizations have their strengths, and how they can work together to do something meaningful. Let's begin. So my plan of presentation is this. I'll give a bit of context of Tamil Nadu. Then we'll go through some slides on TN-KET implementation. Then some discussion on how operational and implementation research guided TN-KET. And finally, effect on TB death rate in routine program settings. Let us start with context. So Tamil Nadu is a southern Indian state. All of us know has one of the highest per capita GDP, and it also has one of the highest HDI in the country. It has a separate Directorate of Public Health, which takes care of primary health care. It has a Directorate of Medical and Rural Health Services, which takes care of secondary health care, and it has a Directorate of Medical Education that takes care of tertiary health care. When it comes to the National TB Elimination Program, under the state TB cell, there are 35 TB program districts. So out of these 35, 5 are in Chennai. So the remaining 30 are the remaining, if you exclude Chennai, there are 30 NTP districts in the state. Overall, there are around 2,800 public facilities that diagnose TB, starting from primary health center, then your block PHC, then comes your government hospitals, your district headquarter hospital, and finally your medical colleges. Annually, around 1 lakh people with TB are notified every year, of whom around 60%, that is 60,000, are adult drug sensitive TB notified from the public sector. Why I'm clarifying this is because adult drug sensitive TB from public sector was the target of TN-KET, right? So annual 1 lakh notifications, which is around 0.1 million, of which 60%, that is around 60,000 per year, were adult drug sensitive TB notified from public sector. The TB prevalence is around 320, of which per lakh population, of which around 124 per lakh gets notified. If you look at the death rate ranges from 6 to 7%. 6% is the death rate for the 2019 annual TB cohort that was notified. And immediately after the COVID period, the death rate was around 7%. So one can safely say that the baseline death rate is 6%. It slightly increased during the COVID period. Similar death rate was also observed among the adult drug sensitive TB patients that are notified from the public sector, that is 6 to 7%. Key point to notice, around 70% of all TB deaths, even in Tamil Nadu, happen within the first 2 months, and these are called as early TB deaths. With this background, let us start with TN-KET. So when we look at the strategies to reduce TB deaths in this short commentary by Anurag Madhvi Bhargav and Madhukar Pai in the Lancet, they have suggested that there are many strategies to reduce TB deaths, many strategies to reduce TB incidents. You reduce TB incidents, TB deaths will come down. You implement the strategies to reduce TB deaths, again, obviously TB deaths will come down. And one of the many strategies to reduce TB deaths are triage and manage severe disease, develop triage tools and protocols for inpatient care. And this comment, concluded that there's one of the conclusions for that there is a need for triaging using simple to use and easy to interpret indicators that can be applied for all people with TB, even in resource constrained settings. So what we did in TN-KET, so when I say what we did is I intend to mean what Tamil Nadu did. So what we did is that starting April 2022, statewide in all districts except Chennai, adult public notified DSTB patients, which is around 60,000 per year, were triaged at TB diagnosis in the diagnosing facility. And those with very severe undernutrition or respiratory insufficiency or poor performance status were prioritized for referral, comprehensive clinical assessment, and inpatient care, following which they would be discharged for ambulatory DOT. So this clearly summarizes. So at diagnosing facility, it could be primary, secondary, or tertiary level. Triaging happens immediately around the time of diagnosis. If they are not severely ill, they are referred to the treatment facility, which is usually the nearest health subcenter or the primary health center to the patient's residence, nearest facility to the patient's residence, then treatment adherence and treatment outcome. If following triaging, any one of those three conditions is present, then the person is classified as triage positive, which is equal to severely ill, which is equal to presence of very severe undernutrition or respiratory insufficiency or poor performance status. So these severely ill adults with TB are prioritized for referral, comprehensive clinical assessment and inpatient care, followed by discharge for discharge to the treatment facility where the regular thing continues. Now, what we did is that we introduced a triage tool, which was already recommended in literature by Anurag and Madhvi Bhargava in one of their publications in 2020. They suggested that using BMI, pedal edema, respiratory rate, oxygen saturation, and ability to stand without support, which are 5 triage variables for severe illness, one can easily, even in resource constrained settings, identify these 5 indicators, and these 5 indicators will contribute to these 3 conditions. And if a person with TB has these 3 conditions, then they may be prioritized for inpatient care. Please note they had also recommended mid-upper arm circumference as one of the triage variables. I'll later share as to why we did not include MUSC as a triage variable. Or if I don't present, please remind me. So, okay, before I get into that, please note that these 5 triage variables were included as a part of baseline characteristics for any adult with TB. Now, why we focused on adult with TB is because for pediatric TB, there was already guidance within the program that if a child is presumed to be TB, they are referred to a pediatrician, or if a child has confirmed TB, they are also referred to a pediatrician. So again, we don't see any operational benefit in triaging them. A person with DRTB undergoes a basic pre-treatment evaluation. Many of them undergo 7 days of inpatient care in the DRTB centers. So therefore, again, we did not see any operational benefit in triaging them. We focused on public notified patients because let's begin with public notified and rest, private notified, we can expand it later. So this was based on brainstorming with the state at the beginning that we first we focused on adult public notified drug sensitive TB patients. Now, if you look at the heading, certain paper-based triage tools were introduced. Let me see if I can drag this somewhere. Yeah, excellent. So the paper-based tools were a triage tool in each of the 2,800 facilities that diagnose TB. Then in around 150 nodal inpatient care facilities, which were mapped before April 2022, with around 600 to 900 beds, the TB beds that were earmarked. So in these nodal inpatient care facilities, a case record form was introduced to ensure basic minimum comprehensive assessment and documentation of inpatient care details if a triage positive is referred to one of the nodal inpatient care facilities. And if the triage positive also has very severe undernutrition, in addition to case record form, we introduced the F75 clinical tracking tool. So these 3 were the paper-based tools that were introduced. The e-tool that was introduced was Severe TB web application, TB Seva in short. TB Seva was the e-tool of TN-KET. In addition, we also developed a 70-page inpatient care guide, which would guide, inpatient care if an adult with TB was admitted in one of the nodal inpatient care facilities. All these things, are available in your TN-KET SOP. And for, for a programmatic point of view, we understood that differentiated TB care is beyond the scope of state TB cell, and it cannot be implemented without the support of the health system. So appropriate orders were issued by the Directorate of Medical and Rural Health Services, Directorate of Medical Education, and Directorate of Public Health around the time when TN-KET was implemented. Needless to say, the state TB cell also, passed on certain orders or instructions.
I'm sorry, Dr. Hemant, you are muted.
How long is this?
Yeah, now it is clear. Yeah, just
How
a
long
few
was it?
seconds.
Okay,
Few
perfect.
seconds. When
Thank
you
you.
started this slide,
Perfect. Okay.
Yeah.
So as I shared before, TN-KET was implemented in routine program settings. That means that whenever TB program was monitored as a part of a quarterly performance review at state or district level, TN-KET also would be monitored. In other words, the quarterly performance review will have many slides monitoring various aspects of the TB program. One slide would be on TN-KET. So this MNE happened as a part of routine. So these are the various, on the left-hand side, you see some process indicators were introduced, some quality indicators were introduced, and on the right-hand side, you can see some output and outcome indicators were also introduced. Let us go through these, indicators. So if you look at 2022, against the 1997 process indicators. So what are these 1997 process indicators? These are nothing but indicators, targets for indicators against the TN-KET cascade. So what you see in yellow is the performance of the state in 2022 against the target of 1997 process indicators. So you see that in 2022, between April to December, of 42,600 adult public notified drug sensitive TB patients that were notified, 93% were triaged. Of those who were triage positive, 71% were referred, comprehensively assessed, and confirmed as severely ill. Of those confirmed as severely ill, 94% were admitted. And of those admitted, the average admission duration was 5. So against 90, 90, 97, the state achieved 93, 71, 94, and 5. Now let's try and understand what is this confirmed severe illness. So confirmation of severe illness was based on comprehensive assessment. Once a triage positive patient is referred in the nodal inpatient care facility, following the case record form, they will undergo comprehensive assessment, based on which they'll be provided scoring. And if the total score was more than 1, using 16 indicators, then one would say that the person with TB who is triage positive is confirmed as severely ill. Basically, confirmation of severe illness was a mere formality unless there was some error in triaging in the field. But the key the key purpose of comprehensive clinical assessment was to identify the reasons for severe illness and address them during inpatient care. On the right-hand side in red, you can see around 11% were identified as triage positive. So if I ask you against 1997 process indicators, which were the two components against which the state did not meet the targets, is the second 90 and the 7. That is, the state was only able to refer, comprehensively assess, and confirm severe illness among 70% of triage positive, and the median admission duration was 5 days against 7 days target. So this is the point to note. Even after 3 quarters of implementation, even for a state like Tamil Nadu, even after having simple triage criteria using 5 triage variables, 5 and 3 triage conditions, after 3 quarters of implementation, even for Tamil Nadu, it did not meet the 1997 process indicators. So imagine if this is implemented in other states. Hence, one of the evidence in favor of having simple triage related indicators as a part of differentiated TB care. If you look at 2023, with sustained efforts, the state achieved the 1997 process indicators, and this was sustained in 2024 and 2025 as well. Now, as we as we met the 1997 process indicators, in the year 2023, we realized that there were some districts that were meeting 1997 process indicators, but still the death rate reduction was not seen in them. So we hypothesized it is probably because of suboptimal quality of triaging and suboptimal quality of comprehensive assessment and inpatient care. So we started building in indicators for quality of triaging and quality of inpatient care. For example, for quality of triaging, if the percentage triage positive for a district for a quarterly diagnosis cohort was less than 5%, it was assumed to be poor quality of triaging unless proved otherwise. If while tracking the trend of triage positive for every quarterly diagnosis cohort, if there was any dip in the percentage triage positive, it was assumed to be due to dip in quality of triaging unless proved otherwise. If you look at quality of inpatient care, we introduced proportion of severely ill that had total score post comprehensive clinical assessment documented. And you can see that this indicator improved over a period of time. We also tracked one input indicator that with respect to the 600 to 900 beds that were earmarked at the beginning, we wanted to know how many of these are isolation beds along with availability of therapeutic nutrition, because half of those who were severely ill had very severe undernutrition. And this indicator took time. By 2025, out of 30 districts, 22 districts had at least one health facility, either the district headquarter hospital or the medical college, that had isolation TB beds along with availability of therapeutic nutrition. A slide on therapeutic nutrition. This is for adults with very severe undernutrition who have, most of them have poor appetite, cannot tolerate usual solid diets. Actually, high protein or energy dense diet, in fact, is contraindicated for them. So they need to be provided inpatient care, and during the initial stabilization phase, provided therapeutic nutrition. Therapeutic nutrition is in the form of cautious feeding using WHO recommended formula feed that can be easily prepared in hospital kitchen using available ingredients that we already have. For more details, please scan the QR code. It has all the details about preparing therapeutic nutrition, how to provide therapeutic nutrition, the F75 clinical tracking tool, and all those things are available. So within a week of inpatient care, that is stabilization, patients can tolerate the prescribed daily dose of F75, which is around 1500 ml for an adult, and then can be shifted to rehab phase, high calorie and high energy dense diet, and then can be discharged depending on whether they are consuming their high calorie and high protein diet, and along with that, other discharge criteria are also met. Now, other than triaging and diagnosis, there were other initiatives that were also implemented. In 6 districts, there was a Allies project going on where TB champions were providing counseling for people with TB, and were also linking many people with TB for nutritional support. So in these districts, TB champions did additional counseling for those who are severely ill. Under the TN-TBDM initiative from 2025, we added a component of a severe diabetes. That is, a TBDM module was added in TB Seva in addition to an existing TN-KET module, where if a person has TB and diabetes, and if their fasting blood glucose is more than 250 at diagnosis or at 2 months, they would be prioritized for insulin. If required, also be provided inpatient care. Then from 2025 onwards, we also added the a provision of predicted probability of death in TB Seva. So as I shared, TB Seva was the e-tool of TN-KET. Key variables from the paper-based triage tool and case record form were entered in TB Seva. So as and when the triage variables were entered in TB Seva from 2022, it provided whether the person with TB is severely ill or not. From 2025, we also provided the predicted probability of death along with whether the person with TB is severely ill or not. So the advantage, what the intended objective was adding this predicted probability of death, is that the predicted probability of death ranged from 10 to 50% for a triage positive severely ill, and it ranged from 1 to 4% for a triage negative individual. So if there was any subjective inference of severity, which varies from people to people, right, to overcome this subjective inference, to ensure immediate inpatient care of triage positive, we provided that information of predicted probability, which can also be used whenever there is a death audit done. This predicted probability and diagnosis can be used to see whether appropriate action was taken, appropriate and immediate action was taken or not. So there were other activities that were initiated with an intention to systematically monitor and track, but high coverage was not achieved. That is, follow-up triaging. A module was introduced in TB Seva at 1 month and 2 months, where those 10 to 15% that are severely ill triage positive at diagnosis, they will be tracked at 1 month and 2 months. But we never crossed 35% coverage of follow-up triaging at 2 months. Therefore, tracking of 5% gain at 2 months and tracking of 5% gain among very severely undernourished, we were not able to do this. We actively implemented certain initiatives, but we actively decided not to measure or monitor them to reduce the data burden. That is admission among triage positive. So the public health guidance was identify triage positive at diagnosis and prioritize them for inpatient care. Triage negative at diagnosis based on one-to-one clinical judgment and availability of beds they could admit. During treatment also based on availability of beds, they could admit. What STS were recommended as senior treatment supervisors, whenever you meet a TB patient during treatment, just use the triage form. And if you find their triage positive, consider them for admission. So this is how admission during treatment was done. And then prioritizing existing nutritional services among those who are severely ill and among those who had severe undernutrition but did not fall into the triage positive criteria, they were prioritized for early food basket and direct benefit transfer. As an informed decision, we did not, measure or monitor this to reduce the data burden on program staff. So if you look at, monitoring, so we had something, the 1997 process indicators, we had, some quality indicators. What did it translate into TB death rate reduction? So if you look at this, 30 by uh, 30 by, I think 10, chart, each row is one district and each column is a quarterly diagnosis cohort. So for each quarterly diagnosis cohort in a district, if there was a 20 to 30% reduction in TB death rate when compared to the baseline before TN-KET was implemented, we marked it as green. If there was no reduction in TB death rate, we marked it as red. And reduction in TB death rate, it was agreed as 20 to 30% is something of is expected based on our past estimates made in previous publications. I'll share about this later. So 20 to 30% reduction in TB death rate, relative reduction was considered of public health significance. So as you see from left to right, the green is increasing. And if you look in 2024, roughly 22 to 23 districts had reduction in TB death rate in every quarterly diagnosis cohort. If you look at the final row, which indicates the state, right? If you look at the final row, in the last 4 quarters, there was significant state level reduction of TB death rate by 20 to 30%. If you look at the TB death rate by annual diagnosis cohorts, it was 6% in 2019, 7% in 2021, and it was 4% in 2024. So even if you ignore the 7%, assuming 6% was the baseline death rate, so we were able to document a 20 to 30% reduction in TB death rate. So to summarize, even for a state like Tamil Nadu, despite having simple triage indicators, it took 1 to 2 years to achieve 1997 process indicators along with quality of inpatient care and quality of triaging, which then eventually translated into sustained TB death rate reduction. Quickly about how operational implementation research guided TN-KET. First, operational research justifying the use of triage variables. See, it's a no-brainer that a very severe undernutrition, which was measured using BMI, pedal edema, respiratory insufficiency, which was measured using respiratory rate and oxygen saturation, and ability to stand without support, which was measured using, poor performance status, which was measured using ability to stand without support. For me, it's a no-brainer that these should be included as a part of, baseline data for TB patients. But nevertheless, let's see what operational research we did to justify the use of these triage variables. First is, before we started TN-KET in 2020 and 2021, this triage tool was piloted in 16 districts of Karnataka and 3 districts of Gujarat. What we found is that high burden was detected, and we also found this tool to be feasible to use in routine program settings. Now, if you remember, I said that Anurag and Madhavi, as a part of their triage variables, they had also recommended mid-upper arm circumference. So in Karnataka, we found that, it was the mid-upper arm circumference was introduced as a part of triage variables, but we found that mid-upper arm circumference did not correlate well with BMI. Second, additionally, mid-upper arm circumference is required to identify very severe undernutrition only if an adult with TB is not able to stand without support. So therefore, considering these 2 points, there is no additional benefit of adding mid-upper arm circumference as a triage indicator. It is very well required during inpatient care as a part of comprehensive assessment, because if an adult with TB is not able to stand without support, it is mid-upper arm circumference, not BMI, based on which very severe undernutrition would be identified. But in the field, because anyway we are not able to stand without support was a criteria for inpatient care, there was, we did not lose anything by excluding mid-upper arm circumference as a triage variable. Then, because during this time in Karnataka, there was no national level differentiated TB care guidance, and systematic referral and inpatient care was not happening. So we used this opportunity to document high death rates among those with, who were triage positive, or high death rates among those, with individual condition being present. So the dotted line on top is the death rate for those who had the individual triage condition present. So based on this data, we made some estimate that if differentiated TB care involving these 5 triage variables is scaled up and appropriate care is taken, based on the data generated in this Karnataka OR, we estimated that around 20 to 30% death reduction is possible just based on differentiated TB care based on these 5 triage variables. Additionally, if I didn't mention this before, but around January 2021, Central TB Division had come out with differentiated TB care guidance. This is called as a 2021 differentiated TB care guidance. Now, one good thing about this guidance was, for the first time, I think in any TB program globally, it was told that severity assessment of TB patients should be done, and if severe illness is present, they should be provided inpatient care before starting on DOTS. So, but one of the issues we had with the 2021 differentiated TB care guidance is it had 16 indicators. You remember I was talking about 16 indicators which we used in the case record form. In TN-KET, we used 5 triage variables, and those that were triage positive as a public health guidance, they were prioritized for referral, comprehensive assessment, and inpatient care. So the comprehensive assessment was done using 16 indicators. What CTD was recommending is to use those 16 indicators among all TB patients, right? So what we felt that using those 16 indicators for all TB patients, then generating a composite indicator score, then classifying it based on that score into 3 categories is a bit complex and not feasible to do in routine program settings. So we said, why not test it, right? So in 8 medical colleges of a state for a period of 1 month, around the time when we started TN-KET, we said, let us implement the 2021 differentiated TB care guidance, where all patients getting diagnosed in these 8 medical colleges would be assessed using the 16 indicators. What we found that of 557 adults diagnosed with TB in these 8 medical colleges, 70% were comprehensively assessed and 60% were identified as severely ill, that is total score more than 1. So what we inferred is comprehensive assessment is impractical and non-feasible. How did we infer that? If 70% is the comprehensive assessment extent in medical college, it may be 50% in secondary level facilities, 20 to 30% in primary level facilities, right? And then if 60% turn out to be severely ill, we don't have that much capacity to admit so many TB patients. So unless the diagnostic and clinical capacity improves up to primary care level, and TB beds and staff are available to admit almost 60% of TB patients at diagnosis, we decided that our TN-KET strategy this basically justified our strategy. Now, in addition, we are very clear with this. In the field, if you implement a 16 indicator based criteria, a routine program staff, will not be able to differentiate that someone with 89% saturation and someone with elevated LFT, both may require inpatient care as per, the 16 indicator based guidance, or, based on comprehensive assessment, but they will not be able to prioritize, right? So what would happen is someone with elevated or abnormal lab values will also be eligible for inpatient care. Someone who is really sick based on these triage variables will also be eligible. So in resource constrained settings, we feel that those who are actually sick, actually more sick, may not get prioritized for inpatient care. So this was one OR that justified our strategy. Another thing that we did is using the first, not the first year data, but at least data from July 2022 to June 2023 cohort. We had that triage variables also. See, Tamil Nadu was the first state that had these triage variables. We had their Nikshay characteristics also. We developed TB death prediction models, right? We developed model 1, that is death prediction based on all Nikshay variables. Model 2, death prediction based on 5 triage variables. Then model 3 based on model 2 plus potentially obtainable Nikshay variables at diagnosis, and model 4, which is nothing but model 1 and model 2. Let us understand what is this potentially obtainable Nikshay variables at diagnosis. What we said is that based on our experience, the variables on the right, BMI, leg swelling, respiratory rate, oxygen saturation, and able to stand without support, Tamil Nadu showed that we can capture it, and the data showed that they were able to capture this within 1 day of diagnosis. Model 3 basically said that of the baseline characteristics of Nikshay, age, gender, site of TB, microbiological confirmation, and previous TB treatment are easily obtainable Nikshay characteristics. So we can strengthen our, death prediction if you also include those variables in TB death prediction. So what we can see here is that if you look at the area under the curve, model 1 and model 2, the area under the curve are almost similar. In other words, death prediction using these 5 triage variables only is as good as all baseline Nikshay characteristics that are captured. And please note, all baseline Nikshay characteristics are not documented with at diagnosis. Routinely, if you see, they are captured within, it takes usually 2, 3, or 4 weeks to capture them. Hence, the justification to use these 5 triage variables. If additionally, we add these potentially obtainable Nikshay variables, you can further improve the death prediction by the model significantly. So it is this model 2 that we introduced into TB Seva, which provided predicted probability of TB death. So in addition, what we did is following 2025, that is once we stopped TN-KET, we took this death prediction model out of TB Seva, and not just model 2, we provided model 1, model 2, model 3, model 4 as a TB death prediction calculator, so that not just Tamil Nadu, but other states can also use this TB death prediction calculator, which is not a data entry tool, but a death prediction tool, a calculator that provides predicted probability at TB diagnosis. Now, some OR was also done in the initial part of TN-KET, where we identified predictors of not getting triaged, predictors of not getting comprehensively assessed, acted on them to reduce the gaps in the care cascade. We also, did the OR on comprehensive assessment, because comprehensive assessment was poor at baseline, and we identified the reasons for it and addressed it over a period of time so that it improves. We also worked on triage audit, especially in those districts that were meeting the process indicator targets, but they were not, meeting the TB death rate reduction. So triage audit was also introduced, and this was also published. Additionally, though this is not an output of TN-KET, but this is an output of DTAT, Delhi Triage TB, which was basically TN-KET replicated in Delhi, where we were able to document the patient experience, that is of those adults with severe illness with very severe undernutrition who were admitted and provided therapeutic nutrition. You can see that their performance status improved over a period of time. That is, the proportion unable to stand without support reduced significantly during therapeutic nutrition. And we also generated information for the first time that it took around 4 to 5 days to stabilize an adult with TB with a very severe undernutrition who was provided therapeutic nutrition. Quickly coming to effect on TB death rate in routine program settings, just 4 more slides and I'll conclude it. So our question was, among adults with diagnosed with drug susceptible TB notified in routine program settings, whether the use of a death risk triage tool using a simple prediction model based on routinely captured triage variable at diagnosis, when we compare it to standard routine practice, does it result in reduction in early and overall TB death rate? So we did 2 kinds of analysis. One is a before-during comparison. In before-during comparison, all adults with TB in the during TN-KET quarters were considered as exposed, irrespective of their strength of intervention. That is, irrespective of their triaging status, triaging results, and extent and quality of appropriate care among triage positive. So basically, Jan to March 2022 was taken as before TN-KET, and July 2022 onwards, each quarterly diagnosis cohort at state level was considered as a during TN-KET quarter. So each quarterly diagnosis cohort during TN-KET period the TB death rate was compared against the before TN-KET after adjusting for potential confounders. So why did we consider all those in the during TN-KET as exposed? The reason being there were two specific components that contributed to TN-KET exposure. One was triaging and diagnosis and appropriate care, and the second was availability of TB beds. So availability of TB beds was useful not only to admit those who were triaged at diagnosis, but it also helped in admitting those during TB treatment, and also helped in admitting some triage negative individuals if their beds were available based on clinical judgment if the nodal physician wanted to admit. So availability of beds was not restricted only to those who were triaged or only those who were triaged at diagnosis. It was useful for admission during the TB treatment. So therefore, all TB patients notified during TN-KET quarter were considered as exposed. What did we see? Let us look at the early deaths first. So when compared to a baseline early death of 5.3%, in the July to September 2022 quarter, there was a significant 20% reduction in early TB death rate, which was not sustained in the next 5 quarters. And then from January to March 2024 onwards, we saw that the TB death rate reduction was significant. This is basically a reflection of what we saw in the implementation part of my presentation. It basically confirms that after adjusting for potential confounders, starting 2024, we see significant reduction in TB death rate in every quarterly diagnosis cohort, not only early death rate, but also overall TB death rate. We also confirmed this after doing something called as a sensitivity analysis, where loss to follow-up were also considered as death. Our results were consistent even after doing the sensitivity analysis. Now you would ask me, what is this effect that we see in July to September 2022? This is commonly known as lightning effect, that is very common in any new intervention that is implemented because there is an excitement during the initial phase. But this is the true effect that we see, that even for a state like Tamil Nadu, it took 2 years for TB death rate reduction to be seen at state level. I have not presented July to September and October to December 2024 results, but those results also suggest 40% reduction in TB death rate. Now, the problem with this before during analysis is it doesn't adjust for the effect of time. Therefore, we did something called as an interrupted time series analysis. And in interrupted time series analysis, we wanted to confirm that this reduction that we see in the year 2024, was it a significant reduction attributable to TN-KET, or whether it was possibly, again, because of, changes in patient characteristics, or just a reflection of a secular trend of reduction in TB death rate. So what you see here are the unadjusted predictions, where each blue dot against a quarterly diagnosis cohort provides the overall death rate for every district. So you will see 30 dots against each quarterly diagnosis cohort. So you see this continuous line which shows the unadjusted prediction of state level TB death rate. There was a dip in 2024 and that was sustained. The dotted line suggests that if TN-KET was not there, it would have continued like this. So this gap between the dotted line and the continuous line in 2024 is the effect. And it was confirmed through interrupted time series analysis based on adjusted predictions. We got an adjusted RR of 0.79, which was statistically significant. So based on before during analysis, we are getting 40% reduction. And based on interrupted time series analysis, we are getting 20% reduction, both in the same direction, both of public health significance, both of statistical significance as well. And this was consistent after doing sensitivity analysis as well. So one can say that after it took 1 to 2 years of implementation for sustained TB death reduction, and around 20 to 40% sustained TB death reduction was observed at state level. So this is our learnings. On the left, prerequisites is isolation TB beds, therapeutic nutrition, state level government orders, and sensitization of chest physicians regarding objective nutritional assessment and provision of therapeutic nutrition. Keep differentiated TB care implemented based on simple triage variables as a basic minimum public health guidance to be implemented for all people with adults with TB. Then beyond this, additional inpatient criteria and that call can be taken by districts and state based on their local context and resource availability. And triaging has to be done at diagnosis itself, because each TB program staff, health system staff has 2 hands, 2 legs, and 8 hours. They resource constrained. They are, constrained by time. They are, doing a lot of work. So if they have to do one thing in differentiated TB care, that is triaging and diagnosis. Even in Tamil Nadu, follow-up triaging just for triage positive also, we were not able to achieve, high percentage, right? And in addition, monitoring should be done against diagnosed or notified cohort, not against current or treatment cohort, because routinely TB program monitoring happens by current cohort. Finally, just based on my suggestion would be for other states, if they do differentiated TB care just based on BMI, that itself would be a good step to begin, or a first step to begin. Because if you look at the burden of very severe undernutrition, which was 6% in Tamil Nadu, so around 10 to 15% severely ill, triage positive, of which 6% were very severely undernourished. But if you look at Jharkhand, it is 17%. Our recently concluded OR in Chhattisgarh has shown it to be 15%. If you look at TB diagnosed in high-risk populations, just very severe undernutrition is 15%. If you add respiratory insufficiency and poor performance status, it is around 30%. So just managing this 30% itself is a huge task. And as Tamil Nadu had shown, it takes time, even for a state like Tamil Nadu. Hence the justification to implement differentiated TB care using simple triage indicators as a public health guidance. Those interested, this TB death prediction calculator is not part of the 4 QR codes. You may please scan this QR code. And in this TN-KET videos, the first video is the video launch of the ICMR NI's TB death prediction calculator by our director, Dr. Manoj Mureka. And at the end of that video, you see this TB death prediction calculator. It is free for use by states, free for use by anybody who manages TB patients. Using simple variables available at diagnosis, appropriate model can be selected and a call can be taken for inpatient care. That's it from my end. Over to you. Over to you, Shan.
Yeah, thank you so much. Thank you so much for sharing it in a very detailed fashion, the process and the implementation and the learnings from it. I think it is a very scientific process which was followed by the health system, which is not so commonly seen. And the impact also appears to be very significant. So we can now have questions from the audience. I would like to start with that. I have posted 2 questions.
Sham, can I
One is
stop
that
my
what was the role of ICMR
Sham, once
NI as
again?
in this whole process, as in terms of advocacy or in terms of influencing the government in using this thing or in this whole idea? And second was my question was like, what is the status of adoption of this tool by other states in India? Because there are many high TB burden states, and I think this can create wonders in those states. Yeah.
Yeah, thank you, Sham. So, Sham, I just wanted to take your permission before stopping the screen share, so I eventually did it.
Yeah,
So,
sure.
one thing is that, as I shared at the beginning, ICMR and I provided lead technical support in planning, implementation, monitoring, supportive supervision, and operational research. Let me share how. So planning means co-designing. So before we started the intervention, what should be the paper-based tool? What should be the triage indicators? How should the case record form be designed? How can we keep it simple? How to provide therapeutic nutrition? What should be the F75 clinical tracking tool to be used? What should be the monitoring indicators that even a district TB officer can understand and implement, right? So this was the planning and co-design that happened. For supportive supervision, basically, we had a technical support unit. So ICMR NIE, like other ICMR institutes, has technical staff. So these technical staff were linked to districts and states. A similar example is WHO consultants, which are there, right? So they were around,
Yes.
I still have 2 or 3 technical support unit nodal persons who are still in touch with the districts whom they started providing technical support in 2021, because we started preparing for this in September 2021. and we are continuing with TB diabetes. Though we have stopped TN-KET, we have handed it over to the state. They are continuing with the TBDM support, So long-term technical support was provided, and some people were linked to the state, with respect to basically maintenance of the severe TB web application and for developing the reports, not only the monitoring indicator reports from time to time, but we also generated the quality indicator reports. We also generated the death reduction reports, which was all done in routine program settings. And we generated a master PPT from time to time, which has everything. And you won't believe that, once when one of my team members went for a field visit, they told that health secretary shared a letter last week based on a state level review of TN-KET, based on a master PPT that was finalized and internally circulated. So that was an example for us that we were not invited, and we were very happy that we were not invited, and we were telling this from time to time. Please do it as a part of your routine, right? So health secretary released a letter around 23-24 to all the collectors that in all the districts where your death rate is more than 5%, the collector should closely monitor KET, TN-KET. So through this kind of things which happen organically, uh, you know uh, the district TB officers also got support from other directorates, over a period of time. So though the letters were all issued, but implementation, effective support, takes time, right? So therefore, it took 1 to 2 years for all of this to materialize. Finally, adoption. Uh, One thing is we are in constant touch with the Central TB Division. Uh, ICMR and I was part of the group that finalized the updated, revised differentiated TB care, which came out in 2025. We are still in talks with Central TB Division, advocating with them to simplify the existing differentiated TB care guidance so that we can uh, get impact at scale. So that is the current status. However, the TB death prediction calculator is open for use by any state if they want to use it. Over.
Yeah, thanks. Yeah. So actually my question was that what you said, I think that is very relevant. My question was slightly different, that when this concept was taking stage, was it how did the idea got imbibed in the health system? Like how could you achieve a buy-in from the health system that this is worth doing before all the technical discussions and
Okay.
all?
So this is the story. I joined ICMR-NI on 2020 in June 2021. So as a part of, I thought it's my responsibility to go and meet various program managers, at least in Tamil Nadu, because I was selected as a scientist in the Division of Health Systems Research. So agar काम होगा तो a lot of काम will happen with Tamil Nadu. So as a part of those initial introductory meetings, I happened to meet Dr. Asha Frederick, the state TB officer, where I happened to share about this previous piloting of this triage tool that happened in Karnataka and Gujarat in 2020 and 2021. And that's when the chat began. Oh, we have a differentiated TB care guidance, but we have not implemented anything on the ground. But we feel what you're suggesting is simple. Can we take it forward? Can we discuss this? And that's how the discussions happened and took shape. And over a period of time, we worked together for 4 years. And rest, if though you are interested to know the story in more detail, if you guys can search Science Chronicle and my surname, if you put these search terms in Google, you'll get an article that we have written for a science magazine that gives you the story not only from the perspective of the state health system, but also from the perspective of organizations like us, like ICMR NIE, as to how we should do ORIR and what all steps should be taken for us to do long-term sustained ORIR. Over to you.
Okay, thank you. Thank you so much. Yeah. Yeah. So over to other people in the audience. Anybody wants to ask a question?
Yeah, maybe I'll come in immediately, Sham. And
Yeah, sure.
thanks,
Yeah.
Hemant. That was a very, very, I think, powerful presentation. It showed that how using, and the point that you made, a simple tool, which is also doable, which is also very clear. how well it is, accepted and used, and what it translates into. So that's really very valuable. My question is connected to what Shyam asked. That I'm repeating it a bit. That the PHC and PHC team, the secondary hospital, what kind of what motivated, what pushed them to start using it. And the reason why I ask is also because right now we are doing one ICMR implementation research which aims to strengthen the health and wellness centers. So, any learnings, any tips on how to get them to also accept any innovations would be very valuable.
So I'm infamous for sharing this tip, but I'll share those tips. Number one is when we do those discussions with the state, and all my colleagues will vouch for this. We discuss three things, and I've shared this in this article. Uh, Number one is we tell the state, I go with this principle that this is your baby, this is not our baby. ICMR or NI is not going to launch this. It's you who should do it. So if we disagree with this, let's not proceed with it. Number two, it should be implemented in routine program settings using available workforce, and the monitoring also should become part of the routine MNE. It should not be that we do a separate MNE where ICMR NI team is present. District teams are not going to respond to us, but they will respond to if the states can do a review, right? So this was discussed, and a third point that we discuss is that whatever we do, we will co-design, we will discuss, we will agree upon. So these are the three things, and over a period of time, Sanjana, I've understood that funded ORIR में मजा नहीं है. मतलब if you want funded ORIR में, then you become a gulam of the funding कि इस दिन funding start हो गई है. For ORIR, you as an institute should be ready, or I as an institute should be ready that today they are asking some support. We should be able to provide support today. It should not happen, yeah, this is interesting. Let's look for a funding opportunity. Let's apply. Tab tak state program manager itself will change, right? So what we learned over a period of time is to generate untied funds so that whenever there is a need to support, we should be able to do it. And TN-KET was one such thing. How to generate untied funds is a completely different this thing. But I strongly believe, other than pragmatic RCTs, which can also be done, which may also be used as a design for ORIR. Beyond that, I think a lot of ORIR should be done under the umbrella of technical support, and we should club technical support with ORIR. We should, and I feel technical support is a moral obligation of those who are doing ORIR. It is unethical and extractive if you only do ORIR, go in a helicopter, ORIR karo, data lo, publish karo, or nikal jao. I'm being very straightforward. And when you implement it, with it being their baby, they monitoring it, So then whatever findings, even if it doesn't work, it's a finding. It doesn't work. It can be stopped, right? It is not a pressure on us कि हमने एक implementation और ORIR project किया है, काम करना चाहिए, right? Confirmation bias नहीं आना चाहिए. So implement करना है with technical support, following the principles I mentioned. But whatever we get should happen in routine program settings, and we document. So for us, the ORIR question was not whether differentiated TB test should be done based on 5 triage variables. We were very clear based on our public health understanding. But our understanding was, if we do this at state level, for a state like Tamil Nadu, how many quarters or years of implementation is required for it to translate into death reduction at state level? Will it happen even? And if it happens, how many quarters? And this is the evidence that we have generated, that it takes 2 years. And if we can learn from these learnings and recommendations and address them, so maybe we can reduce it to 1 year if this is replicated in some other state. But my answer would be, if Tamil Nadu is taking 2 years to reduce TB deaths by 30-40%, other states will also take at least 2 years. Let's go ahead with that. And let's not implement something over enthusiastically, which sometimes negatively affects what we can achieve as well, right? if we go ahead with something which is non-practical, we are not able to achieve what we can achieve, right? So that is something that we learned over a period of time by working with the state. And as I shared, though the intention was for it to become a health system initiative, which it was, but over a period of time, so initially it was state TB cell led. Then over a period of time, with involvement of health secretary and all those things, it became a health system led initiative. So it takes time. The state TB cell is also part of the health system, but truly becoming a horizontal initiative, it took around 1 to 2 years. Over.
Thank you.
Any other questions, comments?
I have a question. Hello, Dr. Hemant. It was a very hello. It was a very good session. It was a very good presentation also, and very happy to know about the study that you've done. Just related to the study only. Towards the end, did you also find other factors, any social determinants, which were also common amongst patients who were triaged, like as severe? Or also another question while you answer this, was it also related to the increased, like the because you showed that over 2 years, the reduction in TB deaths was also seen. So was it also related to, or was it considered a confounding factor that there were increased identification also, like proportion of identification had also increased? Was it also something related to it? Just wanted to
Exactly.
understand
So
that.
I'll come to your second question first. The 1997 process indicators improved over a period of time. The quality of triaging and inpatient care improved over a time, which translated into reduction in TB death rate. Coming to your first question, see, it was not our objective to study whether triage positive or different from triage negative. Our objective was what is the difference between those who are getting triaged and not getting triaged. Those who are getting admitted among triage positive and those who are not getting admitted. So that is what we did in our OR. What are the predictors of not getting triaged? What are the predictors of not getting admitted among triage positive? What are the predictors of poor admission outcomes among those who are admitted? And we did that in the first quarter of our implementation, and we acted on those findings to close the gaps in the care cascade. We have not done a comparison of those who are severely ill and those who are not, severely ill. That kind of comparison we have not done. Over.
Okay, so as a point, I mean, anybody else can also chip in here. And just as a point of discussion, would it also have been helpful, apart from these 5 criteria, if we could also, if any other criteria would have emerged, which would help us in the field, to also predict, to have another predictor or any social determinant which is connected to it, so that it just gets easier before, this situation worsens.
So the answer to this is very simple, Arpita. No one was stopped from acting upon it. And in fact, districts identified their additional triage variables. Like a district like Karur admitted not only those with these 3 conditions, but based on their local context. They also
Yeah.
admitted those with alcoholism, those having addiction due to alcoholism, and those that were elderly, irrespective of the triage status. So those local decisions were taken based on the local context. But as a state level decision, this was taken, and just to get this implemented at scale with quality took 2 to 3 years. So one is public health guidance and one is clinical guidance. We never came in the way of clinical guidance. And we used to tell this in the field when we used to go for visits. Your hands were not tied before, your hands are not tied now. So this is the basic minimum public health guidance that we expect to be implemented, and all the districts would be monitored against this. Beyond this, it's up to you based on your local context. If you have additional beds beyond to admit more patients other than triage positive, if you have local data to show that there are other patients, please proceed with admitting. And that happened. But we decided not to capture that, because this was not an academic exercise. We didn't want to burden the staff in capturing everything. because then data capture becomes the intervention, not the intervention per se. And specifically, I can share that I can speak of what I said, because what I said whenever I went to the field, that use the paper-based tools as much as possible. Capture in severe TB web application is the decision of your district TB officer. If he or she wants real-time monitoring based on certain reasons, then he will request you to do real-time entry. If he or she is happy with what is getting implemented on the ground, he or she may advise you to enter it just once in a month or twice in a month to generate the indicators at the end of the month. So these are all local context specific, decisions. And in ORIR, so there could have been other factors. There could have been other social determinants, but we were focusing on what we had to do, which was provided as a public health guidance. Beyond that, districts were open to add additional indicators. But this was not measured, and this was an active decision. Over.
Okay, thank you.
Yeah, thanks, Arpita, for those questions. Anybody else? Any other comments, questions?
Maybe I'll come in with one more question,
Yeah,
Hemant.
sure. Yeah.
So Hemant, you mentioned as BMI less than 14 as one of the risk factors, and then you also mentioned that how in some states the numbers really are high, the total numbers. So I'm just wondering if we were to look at another cutoff, let's say not 14 but maybe 13, and what is the impact then in terms of death rate? Has any such analysis also been done, or if it's possible?
So it's easily possible. Please use the TB death prediction calculator. You can change the BMI in that as a continuous variable, and you can see how the predicted probability increases. So if you want, should I give a quick demo of it? The TB death prediction calculator.
Thank you.
Okay? Okay, I'll do that. TB. Yeah. So permit me to share my screen. Yeah. So can you see my screen? Over.
Yes, we can see it.
Yeah. So this TB death prediction calculator is basically what it is that this model 2, where death prediction is based on triage variables, right? So the diagnosing district and level of diagnosing facility are default data, which you'll anyway have. But this triage variables, BMI, leg swelling, respiratory rate, oxygen saturation, ability to stand. So the death prediction based on these variables, which is our model 2, was part of TB Seva, right? So we took the death prediction out of TB Seva and provided it as model 2. In addition, we also provided something called as model 3, which is nothing but triage variables along with these 5 potentially obtainable variables, easily obtainable variables that are captured as a part of baseline characteristics within NICSHE. And if there is administrative will, and these variables are, can be easily, it's like when you diagnose, a patient's age, gender, type, site, and previous treatment, right? Model 4 is basically model 1 plus model 2, where in addition to age, gender, site of TB, microbiological confirmation, previous treatment, we have diabetes, HIV status, and bank details. Now, these things are usually not available at TB diagnosis, hence we didn't include them in model 3. So let us see. We have entered some, data here, which indicates a patient who doesn't have high risk, say someone diagnosed in Coimbatore, primary level facility, BMI of 21, no leg swelling, respiratory rate of 14, saturation 96, able to stand without support, 45 years, gender female, pulmonary TB, microbiologically not confirmed, no previous treatment, not having diabetes, HIV, and bank details are available. So these are all favorable factors. So when I click calculate here, I'm using model 4 here. You can see the predicted probability of death is kind of your baseline death rate, around early death of predicted probability of 2.7 for this individual and 3.1 for others. If you're not from Tamil Nadu, you can just select your, you can select not applicable and use this. Okay. Now, let us use the example of BMI. Please remember the predicted probability of death that this tool is providing of around 2.7 for early and 3.1 for overall. Let us change the BMI to severe undernutrition. So let me change the weight to 35, not 35, 40. Yes, so BMI of 15.6. So it is less than 16. It becomes severe undernutrition, but not very severe. You see the predicted probability increases to 4.3 for early and 5.3 for overall death. Now, this person with severe undernutrition, if they have leg swelling, that means severe undernutrition with leg swelling becomes very severe undernutrition. So if you click predict, you see the predicted probability increases to 6.6 and 7.8. If you further reduce the weight, 35, the BMI is less than 14. And then when you calculate, you can see the predicted probability increasing to 7.7 and 9.3. So to summarize, the overall TB death rate for this predicted probability for this individual is around 10%. Now, if you say the age of this person is not 45, but it is 55, and we know as age increases, you see the predicted probability increases. Let us see, say this individual is an elderly. You know, in elderly, the death rate is high when compared to those who are not elderly. You see, it shoots up 17 to 20.1%. Let us say this is not an elderly person, 45 years, but someone with a BMI of 13.7, even without a leg swelling, okay, very severely undernourished, even without leg swelling, 45 years, and say someone is not able to stand without support. And if you say calculate, you see the predicted probability, right? If you want to say that someone who has a normal BMI, let us say 56, right? Normal BMI, everything appears normal, able to stand without support, yes. Let us say he or she, they don't have a bank account at diagnosis. If I say not available and calculate, you see baseline death rate was 2 to 3%. It is increasing to 7 to 8%. That is just mere non-availability of bank account, which is indicator of highly being marginalized, right? It is someone not having bank details along with respiratory rate of 30, that is respiratory insufficiency present. Look at the death rate, it goes to as high as 11%. So, one can play around these indicators. These are based on 55,000 TB patients that were notified in Tamil Nadu between July 2022 to June 2023, using the baseline data of triage variables, mixture variables, and their outcomes that we have. We developed the prediction model. We put the prediction equation in the back end. So what one can do is to play around this and identify a cutoff above. So you can say what proportion of patients in my district who were notified in the last quarter will have a death rate of above 8%. So that many beds you would require. Do you have that many beds with you? If yes, keep 8% as the cutoff, or just decide based on your baseline death rate. If it is 2 times beyond the baseline death rate and we are able to admit those many patients, you can choose that as the cutoff. So this is the TB death prediction calculator that we have developed. Over. Permit me to stop screen sharing.
Thanks much, Hemant. It's very clear, and thank you for the demo. No more question.
My pleasure. My pleasure.
Yeah, thank you.
Okay, so
you could access this as I shared. If you just go to ICMRNI's YouTube channel, TN-KET is one of the playlists. The first presentation, video presentation is by my director, where at the end he provides this QR code. Or I'm going to email my PPT to Shyam. He can circulate it internally. That also will have the QR code. Yeah, over.
Yes. So for the cutoff, I think you said that we can use a contextual cutoff based on the data or like based on the baseline mortality rates, right? That way, yeah.
Yes, yes. Yes.
Yeah.
I would strongly say that have simple triage criteria, and beyond that use the cutoff. take a call accordingly based on a local context. But once you think as a program, program should implement something as a basic minimum, because then only program can compare the performance across states. And the basic minimum should be basic minimum that can be done even in a resource constrained settings. Rest you add whatever you want to based on your local context. Who is stopping you from providing CT scan to all your patients? करो डालो CT scan करो, किसी ने हाथ बांधे हुए क्या, लेकिन नहीं कर सकते तो वो डिस्कशन करने का कोई मतलब नहीं है. So we need to have basic minimum doable in resource constrained settings using variables that are available at diagnosis. This is very important to understand. You can do a lot of retrospective data analysis for predictors of death, low serum albumin, but is that available at diagnosis for you to take a call, assuming 70% of deaths are happening within 2 months? So using available variables that can be captured in resource constraint settings, how can you act on them and provide differentiated TB care? That is very, very important. Once they reach a hospital in a higher level facility, it's a no-brainer. But even in higher level facility, mind you, we need to implement a public health guidance. I will share the implemented TN-KET in Delhi, but we were not able to achieve a triaging coverage of even more than 50% after 9 months of implementation. In Tamil Nadu, we were able to achieve a 90% triage coverage after 9 months of implementation. So let's not assume things that even these 5 triage variables will get easily captured, right? So there, if you ask me, just start based on BMI. And then add respiratory insufficiency and ability to do stand without support as you learn, because सिस्टम में क्या होता है, मेरा ये थोड़ा हिंदी में शिफ्ट हो जाता हूँ, ये मेरा दृढ़ निश्चय है कि ना जब कुछ करने को बोलते हैं ना, जब कुछ रिजल्ट हाथ में दिखता है ना, मोटिवेट होता है, फिर आप ऐड ऑन कर सकते हैं. हम सबको नोबेल प्राइज चाहिए करके हम कुछ कॉम्प्लेक्स इंडिकेटर दे देंगे, ऑन द ग्राउंड कोई नहीं कर पाएगा उसको, और उसी को 2 साल चलाएंगे, नहीं होगा. See, program staff has to be motivated. I think one question I forgot to answer, that why would the STS collect 5 extra variables, right? So because he was able to act based on those 5 variables, and the health system couldn't refuse admission to these patients because this was getting monitored. And the STS probably got a good name in the community by admitting TB patients, which previously he was not able to do, he or she. He was only doing counseling, which sometimes borders to victim blaming. I'm not faulting anybody here. But, the STS, so, ये थोड़ा तुम मुझे खून दो, मैं तुम्हें आजादी दूंगा, no? तुम admit करो, मैं triage indicators नहीं बदलूंगा. That was our mantra. हम इसको नहीं बदलेंगे, हम data entry को complicate नहीं करेंगे, हम इसी 5 indicator को रखेंगे. You understand what I'm saying? We did that for 2-3 years, and STS, once they saw the value, they would do. But when the program staff are collecting data for someone sitting on top to see a dashboard, that is not how e-tools, that is not the purpose of motto of e-tools. That is an additional output of an e-tool. But then if the primary purpose is to collect data for someone sitting on top to look at a dashboard, then you're going to get garbage in, garbage out. Unless the data that is captured is not locally used by the person who is capturing the data, you will not get quality long-term sustained work happening. So that was one point I wanted to answer as to why we feel that the NTP staff, and over a period of time, as I shared, not just NTP staff, the routine health system staff started doing the triage. Yeah, over.
Yeah. Okay. So for Tamil Nadu, what was the cutoff you used for this indicator for deciding admission after triaging?
So Tamil Nadu, we used this death prediction calculator as an additional information to ensure immediate inpatient care. Till 2025, they implemented the 5 triage indicators, right?
Yeah.
Okay.
But so
and
for
they,
5 triage indicators, if anyone was positive from that, then they would consider hospitalization, or was there some score which they used?
Yes. See, their predicted probability, as I provide, ranges from 10 to 50%. The provision of an additional objective value ensures immediate inpatient care. Just severely ill बोलना काफी नहीं, severely ill with 20% chance of death, तो तुरंत admission होगा, right? So हमने simple 5 triage variables, 5 triage indicators, 3 conditions. This predicted probability was an additional information to overcome any subjective inference of severity. And as we move out of TN-KET, we cannot develop TB Seva for the whole country, right? Because it is a username password wala tool, which is a proprietary thing. Just made, they have to enter data. So we provided a death prediction calculator, which anybody can enter and take a call. Rest, it's a local call that they have to take as to what cutoff they would use. Over.
Okay. Yeah. Okay. So anybody else? Any other questions? Okay. So I think we had a very productive discussion. We took like the we generally have it for 1 hour, but we went almost 1.5 hours, and it was like very enriching. So thank you, Dr. Hemant, for sparing the time and sharing this valuable presentation and all the discussion which happened after that. It was very helpful. Thank you all the participants also for this thing, contributing to this thing. So I think we can conclude the session now. Any final comments you want to make, Dr. Hemant?
Nothing. I'm putting it in the chat box. Hashtag TN-KET. Please remember this. Please spread the message. Please advocate for simple health programs, not simple strategies in health programs, not just TB programs. And I'm worried that e-tools are acting as bane, not as boons. We need to advocate for simple tools, simple strategies, and a simple differentiated TB care strategy as a public health guidance. And please remember hashtag TN-KET. Thank you.
Okay. Okay. Yeah. Sanjana ma'am, you want to say anything?
No, no, Sham, just that it's been
Yeah.
a great session, and yeah, very happy to have been here.
Okay.
Okay.
Okay. Fine. Okay. Thank you once again. Yeah, I look forward to that PPT from Dr. Hemant, and I'll circulate it with everyone over here.
Sure.
And this session is also being recorded, so we'll share the recorded session also with everyone. Okay. So thank you everyone again. We can
Sham.
conclude. Yeah.
Thank you. Bye.